Dear colleagues, it gives me great pleasure to welcome you to the second session of the dental track of the World Federation of Hemophilia's Virtual Summit. This session covers topics related to the dental management and treatment of patients with inherited bleeding disorders. The session is delivered with pre-recorded presentations, but there will be an opportunity for questions at the end. I hope you enjoy the session. Thank you.
Hello everyone, I'm Dr. Norjehan Yahaya, specialist in special needs dentistry, all the way from Kuala Lumpur, Malaysia. Apa khabar semua? Or in English it says, how's everyone? Hope you are all well. I would like to take this opportunity to thank World Federation of Hemophilia for the opportunity to actually share our experience here in Malaysia. Now, let's move on to the next slide. Right, in terms of our clinical practice guideline, prior to 2018, there was no available guideline available with consideration of local Malaysian clinical practices, particularly in the management of oral bleeding in patients with hemophilia. So, for our dental care section of this CPG, it essentially acts as reliable references for dental clinicians who emphasize on improving the quality of patient care as well as the services, right? And what we also learn from this whole practice is that the objective of this CPG is to provide evidence-based recommendation on the management of hemophilia. And the development group members were actually from a multidisciplinary team, which include the hematologists, pharmacists, physiotherapists, and for the dental members of the development group consisted of a consultant in pediatric dentistry and myself, specialist in special needs dentistry. So, part of the clinical practice guideline under the content for dental care, we actually covered 3 topics that were reviewed, including preventative dental measures, dental procedures, and management of oral bleeding. So in this particular lecture, I'm going to be discussing particularly on how bleeding is managed based on Malaysian perspective. So or in this CPG, the recommendation for the management of oral bleeding are actually based on the findings of systematic reviews, meta-analysis, and clinical trials, and of course with consideration of our local practices as well. All right, let's move on. So management of bleeding, as we all know that causes of oral bleeding, of course, it start off with eruption of permanent teeth with exfoliation of the deciduous teeth. And in mild form of hemophilia patient, this could be one of the early manifestation of the condition itself. And so in children with hemophilia, the surrounding gum or gingiva may appear bluish and swollen when the baby teeth are erupting or teething. So normally this condition do not bleed. Therefore, it is suggested to allow the baby teeth to self-exfoliate in order to minimize the risk of bleeding. Okay. And in our local setting, extraction may be indicated when the baby tooth is mobile and bleeds. However, the need for factor coverage should be discussed with the hematologist team, alright, which is the primary team in this case, right? And at the same time, of course, with poor oral hygiene, gingival gum, or gum bleeding are always associated with this oral bleeding and induce of trauma, right, whether it's actually iatrogenic, cause or non-iatrogenic cause. And of course, with the invasive dental procedures. Okay, we'll explain a little bit more about that later. All right, now, when we look at this in terms of the management of oral bleeding here, all right, The type of dental procedures significantly affects the bleeding outcome and can be categorized according to the risk of bleeding. Of course, as we all know that high-risk procedures have relatively higher bleeding outcome compared with the low-risk procedures. And of course, yeah, you can actually appreciate from the table here, the risk of bleeding in dental procedures is higher in procedures like plaque elevation, which is part of the periodontal surgery, as to compare with orthodontic treatment, which is a low risk. When you look at the risk of hemorrhage, right, the risk of large widespread hemorrhage, hazarding the airway and being life-threatening. Therefore, I believe that soft tissue trauma must be avoided, such as gingival laceration or cut, because when this happens, then the gingival could actually start to bleed, right? So it is important for us, dental clinician, to practice that whenever surgery is carried out or indicated, it must be carried out with minimal trauma to both bone and soft tissue. Alright? Even in the low risk category, I give you an example of orthodontic treatment. There must be no sharp edges to the appliances, wires, which might traumatize the mucosa and cause the bleeding. Right? So as a clinician, you need to assess the type of dental procedure that you are actually doing, right? And the risk of bleeding associated with this, so that you have a good communication with the hematologist in order for you to provide best of care for your patient. Now, next slide, we'll talk a little bit more about the antifibrinotic agent, which is part of it, tranexamic acid and epsilon aminoglycolic acid therapy. And I believe that epsilon aminoglycolic acid therapy are mainly used in the United States. Yeah. Now, tranexamic acid is a synthetic derivative of the amino acid lysine. What it does is actually exert an antifibrinolytic effect through the reversible blockade of lysine binding sites on plasminogen molecules. So what it does, it significantly reduces blood loss after any invasive procedure, all right, that can cause bleeding in patients with hemophilia. Now, when you look at this, alright, there are 3 points that I need to put and emphasize. The first one is the beneficial in preventing post-op bleeding for dental procedures. Okay, and secondly, cost effective because it reduces the need for clotting factor concentrates and post-op bleeding. And thirdly, no significant adverse effect reported, although there has been some concern about nausea being a common common adverse effect. Now, in terms of how to utilize tranexamic acid 5%, I do understand that in some countries you are able to get the tranexamic acid 5% in a mouthwash form. However, in Malaysia, what we utilize is that we have the capsulated tranexamic acid. So we will actually take out the powder in the capsulated 500 milligram of tranexamic acid to be diluted in 10 ml of distilled water, right? And we would ask the patient to actually squeeze it in around the mouth and should be kept in the mouth for 2 minutes before discarding. For adult patient, in terms of for hemophilia patient, sometimes I will actually encourage the patient to just swallow it after they have done the mouth, rinsing in the mouth for 2 minutes. However, for younger children, it is not advisable because it can lead to overdosage, right? Now, for when there is an incidence of oral bleeding, oral tranexamic acid or the 5% tranexamic acid mouthwash should be prescribed alone or in combination. Can be actually prescribed in both ways. pre and post dental extraction for up to 7 days. Okay, and of course with this, we would actually sometimes have to do a little bit of tell, show, and do in front of the patient, despite them, we have actually explained to them uh, previously a numerous amount of times before on how to utilize this, the capsulated salicylic acid to be diluted in 10 ml of distilled water. But still, sometimes we need to tell, show, and do again to the patient. All right. Now, in our local setting, at the same time, what we do is when there's a bleeding at a particular site, we, with the diluted tranexamic acid, we compress it with gauze soaked with this diluted tranexamic acid until the bleeding stops. Okay, so it's very helpful. All right, on top of the next management that we will look into now. For person with hemophilia undergoing dental extraction, again, like managing any dental, dental management in bleeding, that is associated with bleeding. Any other local measures that can be used, such as, the use of sutures, surgical spleen, and myself, sometimes I use periodontal pack as well, in order to make sure that the bleeding is minimized and compressed on the site. Now, the take-home messages in the CPG, as I briefly mentioned to you earlier, regarding the three types of what we have covered, okay, topics that we have covered. So we recommend for person with hemophilia that the comprehensive oral health care should be initiated early, within the first 6 months after the first tooth erupts, and of course no later than 12 months or 1 year of age. Now, routine dental examination, of course, is really helpful because during the routine dental treatment examination, we provide preventative care measures. And at the same time, we're able to actually, counsel this patient in terms of good oral hygiene practice and, dietary counseling that eventually prevent dental diseases, especially in periodontal disease. Now, at the same time, we also believe that we could emphasize that the comprehensive oral health care in hemophilia should be performed in a multidisciplinary team. So ideally in a hemophilia center, and they should include dental surgeon as well, who are actually familiar with those patients with hemophilia. Now, okay, with that, I will actually like to acknowledge and thank you, our Director General of Health, Malaysia, for the permission to present this part of the CPG management of hemophilia. He has been really great managing COVID-19 in Malaysia as well, right? Now with that, thank you very much for listening. Thank you.
Good morning, ladies and gentlemen. First of all, let me thank the World Federation of Hemophilia Virtual Summit organization and the Dental Committee for the opportunity of being part of this roundtable with these important speakers. I am Dr. Miryam Parreira. I am a dental surgeon and work at the Foundation of Hemophilia in Argentina as Chief of the Dentistry Service. The subject that gathers us today is dental treatment in patients with inherited bleeding disorders. I think that we, as dental care workers, have to share our knowledge as a way to continue learning about different ways to improve dental care in people with hemophilia. I declare that there is no conflict of interest. My agenda consists of showing our treatment statistics from 2014 to 2019, showing our management of non-invasive dental procedures, showing our management of invasive dental practices, and showing our systemic and local protocols. Before showing our statistics, I would like to tell you that our institution, the Foundation of Hemophilia, was created on October 26, 1944. Its mission is the study, treatment, and social health of people with hemophilia. The treatment of people with hemophilia is organized through a network with reference medical doctors who work together in multidisciplinary teams in general hospital services. From 2014 to 2019, we treated a total of 4,547 patients. As you can see, all kinds of dental procedures were performed on this population. These treatments were divided into non-invasive dental treatments, for example, prevention or orthodontics treatments, and invasive dental treatments, for example, dental surgery or periodontal treatments. The most of them were performed during appointments, as you can see in the graphic, which were included in the planning of the treatment or bleeding emergencies in a minor percentage. I would like to call attention to prevention treatment in green, in contrast with dental surgery in brown. As you can see, during the last years, we have tried to decrease dental surgery. Someone could ask why. The answer is simple. Because for us, rehabilitating is very important, as it means the improvement of the quality of life of our patients. This is the reason why, since 2016, we have worked together with the School of Dentistry of Buenos Aires in Oral and Maxillofacial Division 1, where we have been placing dental implants in patients with hemophilia with very good results. To start with non-invasive treatments, we are going to approach prevention treatment. Prevention treatment constitutes the cornerstone of the treatments because it involves a group of measures implemented from the beginning with the objective of obtaining preventive habits and approaching the patients to dental health. We divide the patients into two groups: high risk of dental caries, composed of patients that are scheduled for appointments every 3 months, and low risk of dental caries, composed of patients that are scheduled for appointments every 6 months. In both groups, we use plaque disclosing agents as a way to reveal dental plaque to implement oral hygiene training. And once a year, we organize meetings where we can strengthen our teaching. When we talk about dental procedures, we need to talk about the different techniques of local anesthesia. They are infiltration technique, intrapapillary technique, intraligamentary technique, inferior dental block, and lingual infiltration. Usually, and because we work in a multidisciplinary team, we plan the treatment with the hematologist who implements the systemic protocol in every particular case. For example, in the case of infiltration, intrapapillary and intraligamental injection, it's necessary to increase factor 8 or 9 level to greater than or equals 30%. And in the case of inferior dental block or lingual infiltration, it's necessary to increase factor 8 or 9 level to greater than or equals 50%. In the case of endodontic treatment, our advice is to place the root canal filling within 0 to 2 millimeters from the apex as a way of avoiding the periodontal bleeding. Orthodontics treatment is an optimal tool for the correction of malocclusion in people with hemophilia because it favors the improvement of oral hygiene. In the case of invasive treatments, we need to design a comprehensive plan with general and local measures to achieve a satisfactory treatment without risk of bleeding. Periodontal treatment can be achieved using a systemic protocol and local hemostatic agents. The treatment consists in the implementation of oral hygiene, the treatment of the periodontal pocket, and the maintenance phase, which guarantees long-term oral hygiene and the decrease of bleeding. Oral surgery also can be achieved with the association of a systemic protocol and local hemostatic agents. We highly recommend automatic surgery as a way to maintain the integrity of the socket where we put a local hemostatic agent. This is the systemic protocol. It's necessary to increase factor 8 or 9 level to greater than 50% 10 minutes before procedure. Repeat infusions after 24 and 48 hours to maintain factor levels greater than or equal 30%. In the case of third molar or multiple extractions, consider replacement therapy for 4 or 5 days and concomitant use of oral antifibrinolytic agents. The local hemostatic agents that we generally use are bismuth subgolate, which is a yellow, tasteless, odorless and amorphous powder that is stable in the air but sensitive to the light. It is insoluble in water and alcohol and has been used in tonsillectomies for its astringent and hemostatic properties. This powder activates the intrinsic clotting cascade by activating factor 12 or Hagemann factor. Its chemical structure bears some relationship to ellagic acid, which is a clot-promoting agent that initiates thrombin generation. We prepare the local hemostatic agent with epinephrine, which is a potent vasoconstrictor. It is used in concentrations of 1 in 1,000 or 1 in 10,000 as a topical hemostatic on bleeding surfaces. In addition to decreasing the blood flow, epinephrine may stimulate platelet aggregation. We put inside the wound a bismuth subgalate preparation in a filler consistency. The other local hemostatic agent is trichloroacetic acid 30%, which is a caustic that promotes superficial coagulation. And nowadays, the epidemic of coronavirus disease 2019 has become a major health challenge. Due to the characteristic of dental settings, the risk of cross-infections between patients and dental practitioners can be high. This is the reason why we have modified our services according to the recommended protocols for emergency treatments. And our conclusions are that all the treatments can be performed. We highlight the importance of soft tissue care, multidisciplinary management of dental care, and usefulness of a systemic protocol and local hemostatic measures. Thank you all for your attention.
Well, hello everyone. Thanks very much for listening to this presentation. First of all, my apologies that this is a pre-recorded presentation. Unfortunately, because of the time zone differences, I'm not able to present this to you live. But if you do have any questions, my contact details are available, and I'm more than happy to answer any of your questions. Just before we begin as well, I have no disclosures and no conflict of interest to disclose. So for the next 10 or 15 minutes, what I'd like to talk about is our experience in changing protocols when it comes to dental management for our patients with hemophilia. And this is a project that we've done with the Department of Hematology, which is where we have our Hemophilia and Hemostasis Center, as well as the Department of Maxillofacial and Dental Surgery at our hospital. So just to give you some context, Western Australia, as the name suggests, is on the western side of Australia, and it's the largest state in Australia. And it's only home to 10% of Australia's population. And Perth is the state capital for Western Australia, and Fiona Stanley Hospital is one of the 3 tertiary facilities in the state. And within the hematology department at Fiona Stanley is the Hemophilia and Hemostasis Center, which is a statewide referral center. In addition, we also have the Special Needs Dentistry Clinic, which is also a tertiary, a statewide referral center. And just on the bottom right of your screen is just a photo of one of our clinic rooms. And on the top of that is a photo of Fiona Stanley. So the reason why we did this project is because Fiona Stanley was built about 5 or 6 years ago. And prior to that, the State Hemophilia Treatment Center was based at another hospital. And so when Fiona Stanley was built, the Hemophilia Treatment Center was moved to Fiona Stanley. And so a lot of the guidelines and protocols that were followed at the previous hospital were inherited at Fiona Stanley. And so what that meant for us in terms of dental treatment is that often patients, when they had a dental appointment, would first attend the Department of Hematology, would have factor administered, and then come downstairs to the dental department and have whatever treatment they required. And 24 hours after that treatment, we would give them a phone and just to see how they were going. Now, that factor was administered irrespective of whether you were a mild, moderate, or severe hemophiliac. And it was also administered irrespective of what dental treatment you were having. And we now appreciate that there are some treatments in dentistry which don't pose much of a bleeding risk. For example, it's simple things like fillings. And there are other procedures that do pose a bleeding risk, such as extractions. But in the guideline that we followed previously, it was a kind of a one answer for everything. And this protocol has been around for about a couple of decades. But in that time frame, we've had a number of publications about the oral or dental care for patients with hemophilia, and also reflects a greater understanding of hemophilia and its implications for dental treatment. And for example, this was published by the World Federation of Hemophilia in April 2008. And clearly you see the distinguishing between dental procedures that pose a high or an increased bleeding risk as opposed to others that don't, and how we manage them differently. And in terms of the Australian context, we've also had a bit of research in this area as well. In particular, where much of our protocol is based on. In 2011, the dental service at the Alfred Hospital in Melbourne published this, where they discussed dental surgery with minimal factor support in the inherited bleeding disorder population. And a few years before then, the guidelines for the management of hemophilia in Australia was published, which talks about dental management of patients and what dental procedures would not require factor administration given the low bleeding risk. And interestingly, in that document, one of the authors was from Western Australia. And yet, despite that, these guidelines weren't adopted in the state. And so what we had was a situation where we had a protocol or guidelines that had been used for the last 2 decades and weren't being updated or weren't reflecting our current understanding of the dental management of patients with hemophilia. And so our special needs service approached the hematology department, and we discussed these guidelines as well as the findings from the study at the Alfred. And we came up with a new protocol for these patients, or a pilot study. Essentially what would happen is that patients with hemophilia would first attend our clinic, and then based on our findings and discussion with the patient, we would come up with a treatment plan. And within that treatment plan, there would be procedures that, for example, would pose a significant bleeding risk, such as an extraction, and others that wouldn't, say a simple filling. And we would discuss that treatment plan as well as the bleeding risks of individual procedures with hematology. And then we would do the dental treatment essentially. And we would carry on with phoning the patient 24 hours after the procedure to see how they were going. Now, if you'll notice in this flowchart, we don't mention factor administration. And that's because one of the protocols that we were aiming to use in this study was limiting factor support, but also employing other measures such as systemic tranexamic acid and the use of local measures, say in extractions where we would use a resorbable material to pack the extraction site, but also suturing as well. And we'll go through that in a bit more detail further on. So in Australia, we have the National Blood Authority, which essentially is responsible for sourcing blood products for us. And this is a screenshot of the National Blood Authority's website. And why it's really important to have a look at is because it gives us an idea, for example, on how much each product costs. And our study was done for 2 reasons. One was to see if we would be able to transition to a protocol or a guideline that was more up to date and reflected our current knowledge of hemophilia, but also to see the savings we would have as a consequence. And so over a 3-month period, we saw 11 patients, all of whom were male and ranged in ages from 21 to 79. And we had a combination of hemophilia A, which is a majority, and a couple of patients with hemophilia B. They were both mild, moderate, and severe patients with hemophilia. Now, there's a lot of information in this table, so allow me to orientate you to this. But we had 11 patients, and this is over a 3-month period. And just if you look at the first row, we have, for example, a patient who's 79, mild hemophilia A, and this individual had 4 extractions. Now, those 4 extractions were carried out over 4 appointments. They were in different areas of the mouth. And just at the end of that row, you'll see the amount of factor that we estimated to have saved, and that was based on the table on the National Blood Authority's website. And similarly, in the second row, patient with severe hemophilia A, 22-year-old gent who had a clean and a filling over 2 appointments. And you'll see that the amount of factor that we saved differed, or blood product differed, because there were different products that were used for these patients and different dosing regimens. And so ordinarily what would have happened is that each of these patients would have had factor administered the day of the procedure, and then come to us for their treatment. In this case, none of these patients had any factor administered on the day. For patients that had a diagnosis of severe hemophilia, we organized that their dental treatment would happen on the day of their usual factor administration. And for those patients that were having a procedure that had an increased bleeding risk, such as, say, extractions, we would start them on a course of tranexamic acid, 1 gram 3 times a day, 3 days before the procedure, and then they would continue for about 5 or 7 days, 5 days after. With the extractions as well, we would also control bleeding with local measures, such as packing the site with a resorbable material, and we use Spongestan, and then suturing that over. We would also use some topical tranexamic acid to irrigate the socket with as well before suturing it up. Similarly, in patients that were having a full mouth scale, in addition to them starting the tranexamic acid prior to the appointment, we also employed using a tranexamic acid mouth rinse to help with hemostasis. And so with all of those procedures, in terms of the safety, we only had 1 patient that we needed to see after the appointment, straight after the appointment. So I mentioned to you earlier that we had that 24-hour post-procedure phone call. And we had 1 gent who was age 69 with mild hemophilia A. He had an upper left molar extracted. And after we called him up 24 hours after, he said he was complaining of a constant ooze from his socket or his extraction site. We got him in the same day, opened up the socket, and we controlled the bleeding with local measures. So it didn't require any factor administered. And that was the only adverse event we had. And all in all, 11 patients over a 3-month period, we saved just over $26,000. And so this protocol or this guideline that we've trialed has been has given us very promising results. And what it's shown is that patients with hemophilia can receive dental treatment without the need for preoperative factor. And this trial has shown at least has shown or suggested that by doing so, it's safe for the patient, but also given us a financial incentives for doing so. So just in a 3-month period, we've been able to save, once again, about $26,000. One of the other advantages of this trial, which has been a really big bonus for us, is that using this data, we've been able to transition routine dental care for people with hemophilia to community dental services. Now, because our dental service is a specialist service and is statewide, often we have lengthy wait lists, and getting an appointment can be a bit longer than we would like. And so by offering the service in community dental services, patients are able to get their care quicker, but also in terms of ongoing care, they're able to receive that as well. What we've also trialed is that obviously with procedures that pose an increased bleeding risk, and us not using factor support for that, or factor support for that, those invasive dental procedures are still being completed or still being undertaken at our service in the hospital setting with the support of hematology. And that's something that we're still able to do and benefit from the financial gains as well. Just before I stop, I'd like to thank the dental service at the Alfred Hospital in Melbourne, who have been very kind with their time, but also have been very willing to share their research and help us out with our pilot study as well. If you have any questions, please do contact me. Thank you very much for your time.
First and foremost, thank you to the organisers of the summit for the opportunity to speak with you today and to share with you some of our ongoing research from the Alfred Hospital in Melbourne. In particular, I'd like to share with you some of the initial results of this particular area of interest for us, which are the postoperative bleeding complications for the inherited bleeding disorder community, in particular with relation to dental extractions completed within our service with no factor replacement. My name is Mathew Lim, and the only disclosure that I have to make as part of this presentation is that I'm the director of the dental services involved in this particular study. As all of you will be well aware, international guidelines have existed for some time advocating for reduction in the use of additional factor replacement to facilitate dental treatment, and in particular dental extractions, with the advent and familiarity of use of antifibrinolytic agents like tranexamic acid. Not only does this represent an important step forward in developed countries in trying to minimize the risk of developing inhibitors within our haemophilia population, but secondarily also offers opportunities for individuals in developing countries requiring dental treatment where factor replacement may be less available. Despite this, there are a number of treatment centres internationally that continue to be very anxious about the use of these techniques because of the reported limited evidence within the literature itself. At the Alfred, we've had a long history of reducing the need for factor replacement for our dental extractions in the inherited bleeding disorder community. We've used protocols now for over a decade, initiated by our previous head of unit, Associate Professor Ian Hewson, that have allowed us to use tranexamic protocols for the vast majority of our dental extractions. Part of the foundation and the ability to do so has been the close relationship which we as a dental service have developed with our haemophilia centre. That enables both teams to assess the individual patient and their risk factors prior to the procedure, and for an open discussion to be had about the potential risk factors, both from the local side of the actual dental extraction itself, as well as from the patient's bleeding history. As a result, now for just over a decade, all of our patients have been exposed to a tranexamic acid protocol as a standard part of their dental care. In addition to that, occasionally additional measures are recommended by the haemophilia team based on their bleeding risk and history. This slide here summarizes our current tranexamic acid protocol. There have been a number of iterations of this over the last decade to try and tweak and refine what we're doing. The current protocol involves systemic exposure to 1 gram of tranexamic acid 3 times daily, commencing the day prior to the extraction. This continues to the day of extraction and 5 days after the extraction itself, so a total of 7 days. The 5 days post-extraction coincide with the post-procedural use of a 5% tranexamic acid mouthwash. Patients are asked to bathe their mouth with this mouthwash for approximately 4 to 6 times daily for those 5 days following the extraction. Of note, this is the most recent change within our protocol. Previously, there were different time periods for the post-procedural mouthwash where they used it for a much more extended period of time. But we decided that for simplicity and given patient compliance waned as we got further into the protocol, is to try and see if maintaining the systemic and post-procedural topical methods at the same time period would assist and result in no significant increase in post-operative bleeding complications. In addition to these systemic and post-procedural and other procedural measures, we also, as a dental team, institute a lot of some very particular local measures in addition to using a local anesthetic with a vasoconstrictor. Once the extraction is completed, we bathe the extraction socket in 5% tranexamic acid mouthwash. We place a hemostatic agent into the socket. In most circumstances, we use Surgicel, which is a cellulose-based absorbable hemostat. We place a suture over the socket to either support this hemostat or, where possible, achieve primary closure, and then apply pressure to the socket as is standard protocol after an extraction, in this case using a piece of gauze soaked in the tranexamic acid mouthwash. We do this for a minimum of 10 minutes or until such time that good hemostasis is achieved to allow discharge of the patient. All of our patients that receive extractions within the inherited bleeding community receive a dental review at approximately 2 weeks at our dental clinic. As I mentioned, our protocol for the use of tranexamic acid has changed over the years to attempt to titrate it to the needs of our inherited bleeding disorder community. As a result, the aim of this study is to review our current protocol and to determine if it remains sufficient to prevent post-operative bleeding complications, as have been with our previous protocols. The secondary objectives were to determine the rate and nature of post-operative bleeding complications in this patient cohort, and to further examine what factors may be related to post-extraction bleeding, and thereby enable us to further target our additional factor replacement to particular patient groups that may be of most need. In terms of methodology, our ongoing study is being completed as a retrospective audit. It includes all patients with a diagnosis of an inherited bleeding condition that receive a dental extraction within our service. The initial results that I present to you today represent a 30-month period between January 2017 and July 2019. All dental extractions, as I mentioned, were managed using the standard tranexamic acid protocol, with a number of patients also receiving additional measures that were instituted by the hemophilia team. This is a summary of the information that we were hoping to look at. We collected data with regards to patient demographics, obviously their medical history, including their bleeding condition, the severity, as well as their ongoing regular treatment, any other medical conditions and medications. We looked at the details of the procedure itself for possible local factors that may be of note, as well as the post-operative bleeding complications. Post-operative bleeding complications were based on a self-reported diary that patients were asked to keep post the extraction procedure until the day of review. Post-operative bleeding was divided into 3 categories based on the responses of patients. Mild bleeding was determined to be the taste of blood and saliva, but not requiring any management by the patient. Moderate bleeding was determined to be oozing at the extraction socket or bleeding with blood in the saliva. That required the patient to place a rolled piece of gauze soaked in tranexamic acid over the socket and apply pressure, but no further additional factor replacement or other measures. Severe bleeding represented those groups of patients who required the need to be readmitted to the hospital for management of their bleeding. The next few slides provide an overview of our initial results into this particular study for these initial 30 months. And during that period, we treated 77 patients and completed just under 200 dental extractions. As expected, there was a predilection towards males in the population, and you can see here that there was a slight over-representation in number of teeth within the other hemophilia group. This represented a number of patients with hemophilia C who required full dental clearances. The 2 graphs here provide an overview of the severity of bleeding conditions within our population on the left side, as well as the ongoing treatment for these bleeding conditions on the right-hand side. Of particular note, you'll see that in each of our populations is a significant proportion. The vast majority of our patients receive no ongoing treatment for their bleeding condition. Thus, the factor exposure or the use of tranexamic acid were the only measures that were relevant to assist us with post-operative bleeding. This graph here demonstrates the perioperative management of these different groups of patients. So you'll see that in all of the the diagnostic groups, except for the other haemophilia group, is that the vast majority of patients, once again, were only exposed to the tranexamic acid protocol. Within the other haemophilia group, as I mentioned earlier, there are a number of patients that with the history of haemophilia C who required full dental clearances, for which the haemophilia team felt they should have prophylactic factor prior to their procedure based on their previous bleeding history. When we look at the bleeding complications, this is a quick summary of our results. Out of the just under 200 extraction sockets, 66 were reported to have some form of bleeding. So this represented about 1/3. Of these, about 20% had received some type of factor replacement or DDAVP prior to their procedure. When we looked at severe bleeding, only 2 patients required readmission to the hospital. One was an 18-year-old female with von Willebrand disease. She received no ongoing treatment but had DDAVP prior to the extraction of her 4 wisdom teeth and general anesthetic. She presented at day 11 with bleeding from the socket of the 3/8. The second individual was a 25-year-old male with a history of severe haemophilia A. He had ongoing treatment with emicizumab. He did not have any treatment other than the tranexamic acid protocol prior to the extraction of his 4 wisdom teeth, and represented to the hospital at day 8 with bleeding from the socket of the 4/8. In both instances, patients were managed at the emergency department by a member of the dental team. Local measures were instituted, bathing the socket with the tranexamic acid mouthwash, applying pressure to the particular site, which was sufficient for the 18-year-old female with von Willebrand's disease to cease bleeding. For the 25-year-old male, a secondary resorbable suture was placed over the socket under local anesthetic to assist with hemostasis. Both patients were monitored overnight and required no further factor replacement and had no further bleeding complications thereafter. We also looked at post-extraction bleeding based on the number of demographic and bleeding and local factors that we had listed earlier. Across all of these, we found no difference or no significant increase in a bleeding complication based on any of these factors, so have then secondarily stratified them by the type of bleeding. As you'll see here, based on the history of haemophilia and treatment, there were no associations with severe bleeding, although there were some minor associations between milder forms of bleeding in haemophilia B and the use of ongoing prophylaxis. For tooth-related factors, once again, there were no associations with severe bleeding, but mild and moderate associations with extractions completed in the maxilla, as well as mild bleeding associated with molar extractions. When we looked at the procedural factors themselves, there were 2 factors, as you can see highlighted here, that were associated with more severe bleeding. Namely the use of DDAVP prior to the extraction itself and the extraction involving surgical removal of the tooth with bone removal plus or minus tooth division. There were some milder associations between mild and moderate bleeding and the use of the tranexamic acid protocol alone and for the procedure being completed under local anesthetic. Based on our ongoing experience at the Alfred and these initial results from this ongoing clinical audit, we feel that dental extractions can be completed safely with no additional factor replacement where there is an established and close relationship between the dental team and the haemophilia team to assess the possible risk factors and where rigorous and consistent hemostatic measures can be implemented by the dental team. The use of tranexamic acid protocols in comparison to prophylactic factor present little to no risk of increased bleeding. In particular, we noted that the bleeding complications occurred in those 2 patients after the completion of their formal tranexamic acid protocol and have thus had discussions with the haemophilia team about the viability of increasing the systemic and local exposure to a longer period of time. Once again, further research is required in this area, as is the case in this ongoing clinical audit, to continue to look at factors that may be associated with increased risk of bleeding postoperatively in this population, to further inform our practice, but also to target the additional factor replacement for these procedures to those particular groups that may be of highest risk. Thank you again for your attention, and I'd just like to acknowledge the members of my team that continue to support me in these clinical services, the haemophilia team that we work very, very closely with, as well as the patients within the inherited bleeding community who continue to entrust us with their ongoing dental care. Thank you.
Thank you, everybody. So I'd like to thank you all for your pre-recorded messages. We have some questions that have been popping up during your presentations. I'm going to perhaps direct the first questions to Mathew Lim. I'm aware it's quite, the hour is late or early in the morning where you are. So hopefully we can get through the questions that were directed at you first. So specifically about your tranexamic acid protocol, there was a question about from Cassius Torres Pereira, who said, "Congratulations and thank you for your presentations. Do you have any experience of using articaine as a local anaesthetic to overcome the need for an inferior dentoalveolar nerve blocks? Because I'm assuming your patients don't have ID blocks that require extra hemostatic support. Is that right?"
Yes, I think that's a fantastic question that's come up from Cassius, and I thank him for that particular question. I think that the use of articaine in particular to provide anaesthesia for local anaesthesia for lower teeth extractions in particular has been one of the main factors that's allowed us to have the success with using the tranexamic acid protocol, because we're avoiding the risks associated with developing a hematoma associated with giving a block in those situations. It's one of the factors that pushes us towards being able to use more local hemostatic measures as well as using our tranexamic acid protocol.
So if you needed to use an ID block, would you get prophylaxis on board in terms of hemostatic support, or you wouldn't?
So in most situations we do. If for some reason the articaine infiltration is unsuccessful in the outpatient setting, we may speak to the haemophilia unit and then discuss the particular risk factors, and they'll weigh them up based on the individual patient. The only patients that we routinely give blocks to are those that we are treating as inpatients. So usually for removal of wisdom teeth, and that's because that particular group of patients remain in the hospital as an inpatient overnight before being discharged the next day. So it gives us that extra additional period of time to monitor the patient.
Okay, thank you very much. There's another question from Matthias Kanalski, which could be for yourself, Matthew, as well as it came in during Miryam's presentation. It says, "I would like to know your opinion on the use of non-absorbable silks and an increased risk of bleeding, since non-absorbable silks present a process of fibrinolysis in the post-operative period." Miryam, do you want
I think that, yes, I understand it because it was with some delay to hear you, Lochana, but I think that is very important and very interesting, the use of seals in prophylaxis, in dental prophylaxis. I don't know if I can answer the question.
I think the question was about non-absorbable silks. So I guess, has anyone had experience of using non-absorbable silks? And do you think they're better or worse?
No. Then I please forgive me. I don't understand the question. No, we don't have experience about it. Unluckily.
Mathew or Dr.
Can you hear
Yahaya?
me?
In Melbourne, we don't use non-absorbable sutures for extractions. We use all resorbable sutures. I think in regards to whether it would present a process with fibrinolysis, I think there's some evidence about, in particularly in braided sutures, the impact that may have in terms of plaque accumulation around the actual suture itself, and whether that may cause an inflammatory process. Whether or not there's a particular type of suture that increases fibrinolysis or increases inflammation, I think the reality is that we all have a preference for certain materials that we tend to find that work better in our own hands. And if someone's using a particular type of suture and they find that that's better than another, I don't think that any of us could say that Vicryl is better than monocryl, is better than silk, or better than anything else. Ultimately, when it comes down to it, we use what we have available to us.
That's good.
And I believe that, but at the same time, I believe that in terms of using resorbable resorbable material, it actually provides patient comfort. And if you have to resuture the area, you don't to really remove the suture. Instead of if you use like a black silk, you might ended up having to remove the suture and ended up, further traumatizing the localized area.
Thank you. One of the haemophilia nurses in the UK, Wandai Maposa, he commented that neat tranexamic acid, the IV solution placed directly in the socket or the gums, also has a really good topical effect. That's a good point. Some really couple of interesting questions. I'm mindful of the time, but there's an excellent question from Parimal Chandra Debnath, and I think I'll open it to the whole panel. Is gum bleeding increased in the cases of mental stress or tension? Has anybody had any experience of that?
Not aware of that, actually.
Anyone? Now, I had a patient who...
Not in particular. We haven't had any experience of that in particular.
No.
I had a patient who was a bruxer, chronic clenching and grinding with poor gingival health, and they did bleed quite a lot. So no, I'm sorry, Dr. Debnath, no experience there. Patricio Gatti, who's one of Miryam's colleagues, he said, did you study the gingival health status in relation to postoperative bleeding? I think that was directed at Matt.
Yes, we need to see the gingival state to make the dental surgery. It's very important to start in a good health of periodontal good health to design the protocol of dental surgery in this kind of patients, in all of them.
Okay. Thank you. So, Dr. Yahaya, sorry,
you can call me Jehan, it's okay.
It's really nice to meet you, and we're really sorry we didn't get you in person in Kuala Lumpur. But Mohammed Soliman says how to deal with gum inflammation. So is that covered in your clinical practice guidelines?
Yes, correct. In our clinical practice guideline, when you look at it, there's emphasis on preventative dental therapy. So it means that patients should be advocated to come for, their frequent recalls, preventative measure, doing scaling, routine scaling, polishing, and topical fluoride therapy or anything that relevant to their gum health, such as the use of, for example, like what we use in my local setting, we use Cevitec, which is a product that consists of both fluoride as well as chlorhexidine in terms of the content of the material. So to deal with gum inflammation, proper brushing, flossing, and routine dentistry is very important.
Right. Does any other panel members have any comments on that? I think we also feel very strongly that if you get the gingival inflammation resolved, then postoperative bleeding is proportionately reduced in terms of risk. Do you agree?
Mm-hmm. Yep,
yes.
Definitely.
Yes, definitely.
Well, what can I say? We've got to the end of the Thank you so much for being here. I'd like to thank our guest speakers for your pre-recorded presentations. They were all excellent. I'm sorry we missed Dr. Sundaresan, but Thank you for everybody who's been participating. It's nice to have the questions live coming in. Everyone's listening. So I think we've come to the end of our second session for the dental track. I hope you've enjoyed it. Please feedback. And I'm sorry we didn't meet to see all of you in Kuala Lumpur, but we hope to see you all again at the next session. Thank you so much. So that's all from us. Unless the speakers had any last final comments. Any final comments?
It's just too sad that you can't come to Kuala Lumpur, but you know, after all the COVID-19 is over, you're most welcome to come and visit Kuala Lumpur.
Thank you so much.
Thank you.
Jennifer Kearns would like to say thank you so much for having. Jennifer Kearns would like to say thanks so much for having dental. So we're very glad to be here too. Thank you.
Thank you.